to make it as a connecting between all the specialties. So by starting by that speech, I will start with going, it's freezing, okay. Why we do the endo? For two reasons, okay. The first reason is the remove and reduce the bacteria. Now, I could say to eliminate the bacteria, but unfortunately, we are not 100% sure that we can remove whole bacteria. So we say reduce. So this is our first goal, is the bacteria, how to remove it. Further, after that, okay, when we remove the bacteria, okay, we can save the teeth. So this is our main goal in endodontics, to remove the bacteria and to preserve the teeth. By that, okay, we have a big problem and a dilemma, okay, in our literature, in the endo literature, because we have two big problems, is the success and the survival. Now, when you see the bars going down for the success and going up for the survival, okay, I'm making a big debate here between the specialties, okay, because people look for the endo as unsuccessful, okay, or it's survival, and what's the difference? When we have a root canal, okay, and it's been done a year ago, and there is still a persistent lesion, does that mean the tooth is failing, or it's succeeding, or is survival? As long as the patient is not having any sinus symptoms, as a sinus tract or pain or anything, okay, we put it under the category of the survival. But other categories can be, say, functional. Success, okay, we are very strict in to choose the success and criteria of the survival in the endo, and that's why you look to the bars going down. Otherwise, maybe another field like the implant, they're going higher with their success of their implant to the level of the success. So they use the survival, okay, and that's good for their field. We are sometimes very aggressive in our field, okay, of the endo field, okay, and we choose to pull it down. We want the quality, we want to be the ideal. So if there is no lesion, okay, that means it's success, which is unfortunately not of all the time. We can have it in 1 or 2 years. The healing of the process of the lesions takes longer time. It takes between 1 to 2 years. That's the healing process. It could take longer. It depends on the patient, on the medical compromise, or what's the quality, and many things. And we do a recall, okay, till 4 years. Does that mean, okay, the patient cannot have a crown or a post all of this time? No. As long as the patient is leaving the chair and he doesn't have a sinus symptoms for first 1 week or 2 weeks, you can go for the crown or the bridge, okay? You will not wait for the lesion to heal. And that's the point, okay, also from the endo, okay? We did the first work, which is the removing the pain and the sinus symptom the patient has. And then you can go. Because when you do the faster, the crown and the post, you're increasing the success of the endo, because the sealability at the coronal part will be higher. So I need it. Okay, you cannot leave the tooth, okay, with a temporary or just with a restoration. It might fracture or crack. At that time, the failure is not because of the endo. It's because it didn't or hadn't been restored. So our concern, okay, if we have a non-surgical root canal treatment is not possible, okay, for any reason, okay. I did a root canal, I did a retreatment, and still I have a problem. Or I have a persistence, okay, still I have a problem of a sinus, okay, tract, or there is a sinus symptoms that the patient has. At that point, where should I go? Should I go for extraction? No, there is a one step before you can say that tooth is dead, you can go for extraction implant. Is the endosurgery, okay? We can give it a chance because it has a higher success nowadays than before 10 years ago, okay? Because of the advancements that we have, and this is what we're going to talk about it in this lecture. Now, the indication for the endodontic surgery, okay? Difficult anatomy, that could be from the clinician, him or herself, okay, during the axis or the curvature. Sometimes we can't reach to the end of the tooth. The end of the tooth, okay, is where the bacteria is there. When we look to the periapical lesion, okay, that's an inflammation. It's not an infection. The infection is inside the root canal, is inside the canal itself. So we want to go and clean and shape that root to make our disinfectant can reach to the bacteria. Second thing, if you have a difficulty because of the mishap of anything that can, from the separation of the files or maybe a perforation, that can block me from going to the bacterial accumulation at the end of the tooth. Now, a persistent disease, I could do everything, okay, perfectly with all the materials, all the instruments, but still I have a persistent. It could be, okay, a large lateral canal. It could be another, okay, source. Especially we are dealing with the bacteria, what we call a biofilm. These biofilm, it's like aggregation of bacteria, can live together and feed each one the other. So it's not easy, okay, sometimes to reach to the fins and the isthmuses inside the canal. So we go with these cases with the endosurgery. What's the contraindication? Okay, we have general and we have local. When we say general, okay, we talk about the patient factor, psychology of the patient. Not every patient can be sitting on the chair and you say, yes, I can go for a surgery, okay? You need the cooperation, you need the acceptance of the patient, you need to understand, and you can deal with him during the surgery procedures. Also, from a medical point of view, okay, if the patient have like a bleeding problems, you need to see what's the INR. You need to know the type of the bleeding disorder. If you're talking like a hemophilia and these medical compromised patient, these are need something different, okay? It's like a hospital base or a factor replacement. So it's really dependent on the patient factor. Clinician factor is like the skills of the patient, of the physician. If the clinical or the clinic, okay, has all the instruments and the tool that you have, doesn't that mean, okay, if the doctor, okay, is not skillful, okay, he will go for extraction? No, he should refer that patient, okay, to a skillful, okay, physician, or he can do the work. And that's a big difference, okay. So the first one, okay, is contraindicated because of the medical compromised patient. But the second one, no, you need to refer him or her for someone who can do the surgery. Local factors, it depends on the many things. Dental factors, looking for the tooth itself, going for the crown root ratio. You can't only focus on how much you can remove from the root, okay? You want to see how much is the restorability of the tooth, how much still left from the tooth. Anatomical factors, we are looking from the vital, okay, anatomical organs, okay, nearby the surgery. We're looking for the palate, okay, for the arteries, okay, for the lower, okay, for the inferior alveolar nerve, okay, or the mental nerve, how close we are. And that's why we have this valuable tool, the CBCT, okay? You can use it, okay, and you can see how much is the risk and going for these kind of cases, especially lower molars and upper molars. Surgical access factor, like the lower molars, okay? We have the external oblique ridge, okay? You want to see how much of the bone you have. The upper, okay, for the palatal root, you want to see how much is it steep or shallow is the vault of the palate, okay? Is it worth it to go for a surgery or just go for extraction or implant? Or you might see something like a new advanced techniques, okay, had been used, okay? I will show you in the coming slides. These are the contraindications. But before all of this and after the starting and choosing the patient, we need to do an assessment. The full medical and the dental history of the patient. This have to be thoroughly going with the patient. The patient has to know what's the expectation. And the minor, okay, things, okay, that he might not expect it. Like, for example, a thin gingiva, he might have a recession, okay, or like a thick gingiva, okay. This is the type of the periodontal, okay, bite type, okay. You might have a pocket formation, you might have a scarring, you might have a bruising. These minor things that you think it's acceptable, maybe other patient will not accept it. So you have to be frank with the patient in all the details that he might see after the treatment. He might not have it, but you should tell the patient everything. Now we'll go for something in an advance or something of the surgical equipment that we needed, okay? And some of it is a little bit, we have it in I use it in the NYU. And I couldn't find here back, and I will show you some of these equipment. The microscope, it's a must. It's a must, and it's not an option, okay? Surgical and surgery, okay? The success of the surgery had been rising up because of the microscope. Beside the material, but the microscope is a must. Do we need to use it in all the procedures, starting from the injection to the suturing? No. The more focus that you want to use it for is during, okay, the crypt preparation, when you cut the roots, okay, and you need to go there, okay, and you want to cut it, and you need the focus, the magnification from the microscope. This tool, which is the endoscope, I use it in the NYU, okay, and it was one of the first people, okay, that Dr. Rosenberg he brought to the clinic, and they made it like a holding bag, okay. It was acceptable in the way how much it cost, okay. It's almost like $15,000 compared to the microscope. Now the studies shows that no differences between the outcome, even though, okay, the endoscope, it's much more focused. And the good thing about it is the head or the tool that you have, okay, to hold it inside the patient. You can use it as a retractor and you can focus it. So the endoscope is one of the big advancements, and it's one of the best thing that you can use it. Even if you have multi-clinics, okay, you can't move the microscope with you, but you can use the operating endoscope to use it. Even it's a good thing for other specialties. So this is one of the advancements and one of the good things, okay, for the surgeries. The tools or the instruments that we have the micropluggers, microcarriers, and even the periosteal elevators. Even we have the retractor reflector, okay, which is a micro, okay, from the original one. It's thinner, okay, it's almost like 1.5. Micro mirrors, okay, you can see the original, okay, mirror, how it look like, and you can see the micro mirror, okay, when we use it inside the surgical part. These increasing the success because we are using the microscope, looking to a small mirrors, okay, inside the surgery. We use the ultrasonics, okay, we are not using the handpiece inside to drill inside the retrograde or making the preparation. So we use the ultrasonic with the diamond coated. Even we have a longer size, can reach to 9 millimeters. We have the rear vented, which is the 45 angle. And this is something could be a good thing for the COVID-19 because this type of handpiece, it's a rear vent. That means it blows the air from the back. It doesn't push it in front because this is reduce the emphysema inside the surgery. These type of the tools, it's called the MAP system, micro-apical placement, which you can use it as to place the material inside the crypt, okay, when we are packing the material inside the retrograde preparation. Blades, which is most of us, okay, using mostly the 15, 15C, 12, and 11. But there is the micro blades, which is used by the perio. For us, okay, this is a big advancement because some of the flap designs, it need these, okay, type of the blades or the micro blades because it's very important, okay, how to reflect and to be delicate with these tissues. Piezoelectric, okay, also it's used by the surgery, okay, and by the perio people. Okay, we can use it also, especially when we are dealing with upper molar that's close to the sinus, okay? So it's easy and it's much more gentle, okay? Handling the Schneiderian membrane without tearing or perforating the membrane. For lasers, okay, still an advancement. It's not yet performed in everywhere, but it's still one of the advancements. The problem with it that you need to change the head because of the intensity. When you are cutting with the soft tissue, or you're going with the hard tissue. So you need to change the head. Still is not accurate to cut it in a good way, but still one of the advancements that can we be used during the episectomy for the endosurgeries. Now, these are the instruments and the tools, and we'll talk about the anesthesia and analgesia and the disinfectant. Do we need to use it, or there is any difference, okay? We're going with the 2% lidocaine with 100 to 100,000 epinephrine. That's the ideal. And we go slowly in each teeth. Okay, we are going to deal one tooth after and one tooth before. And we use also the 150,000. Now, this is one big issue because we don't have it here back in my country. So we go with 180, but it's not like 150, okay? This will reduce the bleeding. So this is the way how we should go with anesthesia for the endosurgery. For the analgesia, okay, it's proven, okay, that you can go with the pre-medication. So the patient, before he starts the surgery, 1 hour before, He can take ibuprofen if he's medically fit, okay? If he has a problem dealing with the ibuprofen because of the whatever bleeding disorder, he can go with the acetaminophen. And we can go also with the long-acting anesthesia, like the Bupivacaine. This can give it to 8 hours. So we want to make the patient comfort with no pain, which we call the profound, okay, from all the pain, before, during, and after. Because this process and this procedure, okay, it's an extensive procedure because we are doing like a trauma to the tissue and to the bone. So the patient needs a time, he will have pain later on when he leaves. Do we do a disinfectant before? We can go with the chlorhexidine, okay, 2.2%, okay, 1 minute before the surgery. Some will use the iodine disinfectant over the area where you want to do the incision. Now, if you have any questions or anything, you can put it in the question box, okay, and I can answer it, okay. If I have many questions, I can stop and answer, but I can't see any question later on. So I'll move on, okay, with the next step. So the corrective surgery, okay, it's not only episectomy, okay. We have many surgery that can be included with the endo, which is the perforation repair, root amputation, hemisection, and bicuspidization. We still have another things can be added to the corrective surgery, like the intentional replantation or transimplantation. But we are looking to the obvious that we have most of them. Some people look to these type of treatment, it's an old treatment. But there is nothing old, especially when you have economical crisis, patient preference, okay? And even the situation, the clinical that have during this time. So when you go for a perforation repair, because of the advancement of the material that we have to repair this damage, we have the MTA, we have the biodentin, and we have the endosequence, which is the bioceram. So we can go with the pulp capping, considered as a direct pulp capping. Nowadays, they're using the MTA. It's much more advanced in the dealing with the pulp tissue, dealing with the damage that can happen from the perforation. We can have a full, like a pulpal floor, okay, perforation. Could have it, okay, also we can use the biodentin and we can use the bioceram. We can have in the root, okay, itself, lateral perforation. So a case like that, when you look to it, okay, you'll say, okay, we have a large post and we can see the radiolucency on that side, but we have a long span bridge. What's the option that we could have? If you think, okay, that's a hopeless tooth, let's extract it, okay? Then we'll think of an implant, another implant. And he wants to maintain it, economical status, whatever the reason. We can go for a surgical from that point. And we can go, okay, and try, okay, to save the tooth. So we can open an exploratory surgery and look for it. How much is the damage that had been done to the from the post to that area? And we can seal it. We have the good material, the MTA, and just follow up. This is a good case that can stay for a longer time. Yes, it can go with the implant and whatever other treatment, but still there is an alternative treatment, which is the perforation repair. This tooth, which is I did, okay, it's a tooth number 3. A patient came who has a sinus tract and he has a swelling. So when we trace it, okay, it was reaching to the mesobuccal root. And the patient already had 2 years back an endosurgery. You can see the cutting of the root. The complaint of the patient was that I don't want to lose this tooth. I said to him, okay, you have already an implant. And he said, okay, economically, and even though I don't want to have that experience back with the implant, I want to try and save it. I said, okay, it's a trial. Okay, I want to be promising you that it might work. Because the only option I have here is to cut the root, okay, from the whole post. And that's what I did, okay? So I cut the root, okay? And I placed a calcium sulfate. Calcium sulfate, it's a material that can be used as a bone graft. The good thing about it, okay, which is the advanced now, you can set it quickly and you can suture. The only thing that if there is any escape of any liquid or anything, it can easily to resolve. And I just called the patient 6 months later on, I was surprised, okay? The healing I had in this case, it was unexpected, honestly, okay? But maybe because if I looked at this case, if I did it again with another patient, could it be successful? Maybe, maybe not. But this case was successful because I think because the mesiobuccal root was two layers that goes from the buccal to the palate. So the case now, it looks like a cantilever. I followed for a year, okay? And that time, okay, I saw it. It's amazing because when I look to this x-ray and I look to the implant and the tooth near to it, this tooth, okay, it has a crown, it has an endo, it has an epicosurgery, and it has a root amputation. It says to us, okay, I still have the capability to survive, okay? You cannot extract because you want to extract, but still you can give the chance for a tooth, okay? God-made creation is not like a human being creation, okay? Even though, okay, look into this case, okay, it's interesting that it's still functional, okay, and the patient is still maintaining and cleaning and shaping that tooth. For a hemisection, okay, even though, okay, we have the distal root, which is fractured, the patient doesn't want to go for implant, you might go and do a root canal for both canals, okay, and then you might remove the distal root, and you can just make a crown and just attach it to the neighboring tooth. Still a valid treatment. It might work, it might last for a longer time or no, but still it's a part of the treatment. Implant is a success, but if the patient doesn't want to, you still have an alternative options, then you might go for a hemisection, amputation, or whatever case it might be, a bicuspidization. When you have like this case, this patient, if you look, you have a generalized periodontitis, okay, and if you go for implant or whatever, it might not work. So you just just make it two premolars, okay, and you might go and crown both of them. It might last for some time, but even though, okay, these roots can last longer, okay, with this length, more than if it's an implant with this short root. Because a patient from your field of as an implant, if it has a periodontal problem like the pre-implantitis, okay, the success will be less, okay, compared if it's a natural tooth. This is what we call the corrective surgery. So these corrective surgeries, okay, it's part of the treatment that we are going with the endo, okay. So it's not only endos and episectomy that's cutting only the roots, okay. No, we can go even with another terms of treatment to save the teeth. Not only, okay, by cutting the apex, no, we can even just go with the treatment options between the pros and perio, and we can make something suitable for the patient. Now for the episectomy, okay, when we go for the flap design, these are basics, but sometimes very important to how to go and handle, okay, the blade, okay, when we do the incision and do the flap design. The free gingiva, attached gingiva, and biliary mucosa, that's important, but the more important to me is the vessels. How much is the blood supply and how's the blood supply? So the periodontal vessels and the alveolar bone and the supravariosteal vessels. The way how you make your incision, you don't want to necrotize the remaining tissue. You want to remove the whole thing. You don't want to know how much of the supply and how the supply is running from that point. So regardless, okay, of the flap design, we want to have enough blood supply and you want to preserve the interdental papilla from recession. That's one of the main things that it changed in the endosurgery. We want to preserve the much we could from the interdental papilla. These are the type of the flaps that we have. Semi-lunar, okay, full thickness marginal flap, submarginal flap, and palatal flap. When we look to the old type of the flaps, semi-lunar, this is nowadays is contraindicated for us as an endo. One thing is the limited, okay, view that you can have when you open and you can access the tooth from the apical point. Second thing, okay, the post-operative pain and the scarring. So it's not anymore used, but I have to mention it because I want to show things that it could be used or not. This is something that is traditionally used, okay, which is the full thickness marginal flap. The modification that we have is when you do the incision, okay, you want to have the incision not anymore to have the broader base, okay? You want to have it now a parallel. Why is that? Because of the arteries moving in a parallel way. You want to minimize how much of the blood supply you want to cut. So, and even though the next one, which is the 90 angle point when we go to the tooth. So it's a parallel, okay, to the arteries, and we touch the tooth, we touch it with a 90-degree angle. Okay, this is the full thickness flap. We have the modification type, which is the papilla-based flap, okay? And the only modification on that, we want to preserve the dental papilla. The dental papilla, okay? We don't want to remove the full papilla. So we just go all over and we just touch the tooth at 90 angle, and we go with the, this is the thing that you need to use it with the microblade. You cannot use the size 15 or 12 because this is a very delicate tissue, okay, and you want it not to be teared when you want to suture it, okay, and you want to place it. So we do it by a 90-degree, okay, and then we change the angle of the blade, microblades, and then you have it in this direction. Now, the good thing about the papilla base, okay, from a velvet, okay, that the type or the amount of recession, okay, it's less than 0.1, okay, in a year, okay, which is very good in aesthetic teeth, okay, where you want to do the surgical in that point. Moreover, okay, than the full thickness flap. So it's a recommended to be used, okay, in the anterior teeth with the papilla base. Going for the submarginal, okay, we're going with the same technique, okay, but we don't go all the way to the interdental papilla. It's sub of the attached. So we go 3 millimeter or below, okay. It depends on how much of the bone that you have, and you just do it in a scalloped way, following the anatomy of the tooth. This is a problem that you might face if you do it in this wrong way. If you make your incision, okay, higher than what you are expecting, you need to put your blade on a bone, okay? You don't want to put it on a tooth, okay? Because you're going to cut the blood supply that we talk about it, and then you have the necrosis. So you need to first prop and check where is your bone, okay, to know exactly how much of blood supply before you do this technique. Lastly is the palatal flap, which is some people they might go and use or know, but the most thing that we are afraid from is the palatal arteries, the neurovascular of the palate. We can go from that point, okay, only the 2/3, okay, the 2/3, okay, from the distance that we have it. And we can go from the first premolar, okay, to the last molar. You can have it as a full thickness flap, or you might go it as submucosal, okay, flap like this way, and then you can reflect. The problem with it is very tough to tense it, okay, and to retract, okay, but still one of the flaps that we can go for it. A technique will be shown later on in how to use another way going from the buccal side to the palatal root. Now, what's the difference also in the flap reflection? One thing is that usually, okay, we go and just make the vertical incision and then we try to reflect, okay, the tissue. We don't want to go from the thinner area. We want to go from the thicker area. You start by 1 and go from 2 to 3 to 4. And by this, you're limiting the tearing, okay, especially this area. For you people, okay, or the surgical, they go with the envelope. Usually we go with a vertical, either 2 release or 1 release. So we are very delicate, especially we want to suture this area. It's a hell of a time if you tear part of it. Some of you, they have the what you call the tissue glue, okay? Not sure how the availability of it, but it's very nice to just glue the area where we have tearing instead of using the sutures. Bone removal and the identification for this. If you have a case like that, some people say, okay, I will go for extraction immediately, but you need to do a CBCT and check, okay? You want to see the bone, okay, how much we have. Sometimes you'll be expected or like amazed when you open a surgical and you find still there is a bone, okay, around it. But when I look to a case like that and I see the amalgam, okay, I will remember this is an old case, our old way of doing a surgery, okay, where they do it by the amalgam and a 45 angle. In a case like that, okay, when we have the amalgam over here and the angle of the cutting of the apical area, okay, is not enough because back of the tooth, okay, from the same tooth tip, okay, we still have the lateral canals. So it's easy that you can cut the tooth tip from that area and to remove the amalgam and just retrograde filling, and you can follow up with this case. But most of the time, okay, the cases, it might be always what you look in the x-ray. This is a technique that's being used by the one from Romania, Gicamano, and he used the implant stent. In a way, he modified it to use it with the endosurgery. So he used the CBCT and he made the guide, okay, as if they're using it for the implant, but he used it like a surgical for the endo. So he made the guide with the axis of the trephination burr, okay, and this is how we want to go. So we are talking about tooth number 16, okay, so this will go for extraction number 17. So he did it, okay, because he wanted to cut the palatal and the distal buccal. So he just raised the flap and he made the stent, okay, and he'd go and he'd drill all the way to the palatal root. Remove the amount of the bone inside, and this is, you can see the two roots, okay, with the gutta percha inside, and then he made the filling with the MTA and done. So this is one of the promising techniques, okay, it could be used, okay. So it had been adapted from the implant and from the stent, okay, to do it in a way that we can save the teeth. And this is the good thing about the cooperation, the collaboration between the specialties that we take in the advance they have, and we take in the advance. Two big things in the surgery that we had been really beneficial from is the perio with the guided tissue regeneration, and the implant from the stent, okay, and the guided. Sometimes we have, like this guide, when we have the blocked canal, they do a guide through it, okay, and they made it all the way to reach the apex by the stent. So it's a way how we can modify other specialties to the way how we can adapt it to our field. Now the curettage, just to remove the tissue from inside the crypt in a way that we have here. Do you think if we left something, does that mean that the case will fail? No, okay, it's not a cancer, okay. The infection is inside the root canal. Okay, what's outside is an inflammation. We try our best to remove what we could, but if there is a close to the sinus or close to the vital, okay, organs like an artery or a vein, okay, we can leave some if we couldn't do it. The problem also with these type of lesions, okay, when we try to remove it, it's very painful to the patient. So we try to give more anesthesia inside, but you have to be very slowly. We might use sometimes the articaine to go and to fill the area inside the tooth, inside the lesion. If they have like a perforation in the maxillary sinus, does this will affect the outcome of the endosurgery? The literature say no, there is no problem with that. So this is from the point if you want to remove it, okay, if you left something or no. How much we remove, okay, from the root apex? We need to remove 3 millimeter, okay? Why 3 millimeter? Okay, because most of the lateral canals, it's last 3 millimeter of the root. And we need to do it at a zero bevel, okay? We need to do it at a zero bevel. We're not doing it anymore like a 45 or whatever angle. We need to do it all the way to cut it, because this is the area where we have the lateral canals. So when we cut this 3 millimeter, okay, we use the ultrasonic later, okay, to go and drill and clean another 3 millimeters. So actually, when we do the surgery, we are cleaning 6 millimeters. 3 millimeter will be cut off, and 3 millimeter to be cleaned inside and filled. A case like that, it can come to anyone, okay. Look into the lesion, okay. I always look to this type of the way how I look to the lesion size and the distribution of the lesion. I call it a lesion map, okay. It can show you, okay, where is the source of the bacteria, okay, can go and fill that lesion. Mostly, okay, the lesion, okay, when you have the bacteria is filling inside, okay, you have the center of the lesion is in the port. If we have extension of the lesion, okay, that means there is another, or there is a lateral canal. Before you do anything, you want to see what's the failure, why this case failed. When I look to it, okay, you will look to it that you have a leaked crown, and you have a space that it has already a post, which is already not fit, and that caused also the bacteria, okay, to be penetrated, and we have a leakage. So you will not go for a surgery in a case like that. You need to retreat. So which one is the risk and benefit? You have to measure it before you go for surgery. So when you do a retreatment, I feel much more confident to tell the patient, yes, I have a good success, okay? To this case is when I follow up. When I look to the sealer puff, okay, I have 3 main ports, okay? And you can see it's holding the 3 areas, okay, of the lesion, okay? And you have a sealed, okay, a tooth, and we have a new crown, okay? That's something, okay, you might think to go with it. Later on, if it's failed or anything, okay, I will go for a surgery, but I will be much more confident to go for a surgery in a case like that, more to go with a case like that, because still I have the access of the bacteria and the leakage is still going inside. Do we always go with the 3 millimeter? For molars, okay, upper molar, okay, and a lower molar, okay, especially with the mesial root, we go with at least 4 millimeter, okay. We want to expose anatomical, what we call the isthmus between the two roots, the mesobuccal and the mesolingual in the lower, and the upper, which we have the MB1 and MB2, okay, the mesobuccal 1 and mesobuccal 2. So we need, like this case, okay, we have all the anatomy is filled. The mesobuccal 1, 2, I have the palatal, and we have the distal. We can easily go for extraction implant, but you can give a chance for the endosurgery, and you can go, okay, and you can cut from the mesobuccal and from the distal, and you can join the isthmus in between. You can see the amount of the root had been cut. It's almost 4 to 5 millimeter, okay, and you can see the case 6 months later on. Still, we can preserve the tooth or the natural teeth by the surgery, okay, but you know, or you need to know how to do it and why you do it and where you do it. And depending on the literature, okay, you can know exactly which tooth you can go with the surgery and how much you can go and remove. For the root end preparation, you can see nowadays how much we are removing from the bone. We are not very aggressive, okay? This is the micro mirror that you have seen in the first 2 slides in the instruments. And you can see the small gutta percha. Now, to see this diameter or this view, you cannot see it by a naked eye. You can see it only by a microscope. So this picture is taken by a microscope. The same thing, okay, when we start to drill, okay, inside the gutta percha that you see in the microscope, we use the ultrasonics. It's a diamond coated, and we go through it with the inside the gutta percha, and then we remove from inside the root, okay, and then we do the filling. Now, the hemostasis, to make the field looks like what you have seen before, we can go with the gauze and adrenaline with the epipellets. It's 1 to 1,000. We can go with the cellulose base. We can go with the ferric sulfate, aluminum chloride, but you have to be careful with the ferric and the aluminum, because after you finish, you need to scrap the bone so you can make the bleeding oozes again. Otherwise, it might cause the post-operative complication, because there will be no bleeding and clotting. So this is about the hemostasis and how we deal with it. Now, for the root end filling, the old times they were using the amalgam. Now, the amalgam is not because of the amalgam itself caused the failure, but even the technique itself, okay, the 45 angle and the way how it's holded, because the way the amalgam has the corrosion and the mercury is not really the failure itself, but because of the sealability that cannot seal, okay, the epic area. Otherwise, we have cases that had been done by amalgam and is still functional and still success. So it's not failure because of the amalgam itself, but because of the technique. The healing characteristic, what we mean by is that the tissue that form around the amalgam is not really the way how it looks within normal. Comparing to the zinc oxide, as you know, the zinc oxide, the cements or the iron or the ABA or super ABA, these are acceptable and better to seal than the amalgam. And the healing is much more friendly to the tissue than amalgam. So if you don't have any options or you don't have the MTA, you must go with the ABA or the zinc oxide, temporary filling, okay? Better than the amalgam. The MTA is the standard, okay? It's excellent root filling material. It's a long sitting time and challenging to manipulate, but you can do that, or you can fix this issue by using the MAP system, okay, which is the microapical placement, okay, and we can have something called the Lee block. Lee block, it's a blocks, and you can make your mix, and you can apply it over that block, and it can form to you a pellets, and easily you can insert it inside the retrograde filling. It encourages the formation of the cementum and an excellent healing. The way how it's formed, okay, around the tissue. This is the MTA and how the tissue, okay, looks to the MTA as a normal. This is a study done now one natural tooth, okay, and one tooth that had been a surgery, okay, and has an MTA. Both looks normal, okay. So the MTA is the closest that you can have to the normal PDL in the apical surgery. Do we have something that it can beat, okay, or overcome the MTA? Yes, we have the bioceram and the biodentin. It's closer, okay, in the way which is better, okay, in the manipulation, okay, and it has the same advantage of MTA. But nowadays it becomes much more expensive because it's a limited amount that can be used. So we have new materials coming in the market, and all of them is competing. And it's not only now becoming like an MTA for only the filling material, okay, for the retrograde. Now we have the MTA sealer, okay, we have the MTA putty, okay. So they started to use the most ingredient success in each part, and they start to produce new materials. This is how it looks like when you have a sealing by the MTA, okay, and it's how it looks like under the microscope, and you can see it with the micro mirror. We just remove the infected area, which is the part of the last part of the root, okay? The other parts, okay, around the crypt, we don't touch it. So we are very conservative nowadays in how to do the surgery with the endosurgery. Now, the guided tissue regeneration, when we go and use it, mostly when we have a large lesions, when we say large, that means above 10 millimeters, okay, and we have 10 centimeters, and we have what we call a tunnel, which we call it through and through lesion. That it means that both the buccal and the palatal, okay, bone, it's already resolved, okay. So these are the good things, and we learn a lot from the perio, okay, most of the time, okay, from the guided tissue regeneration, because when we have loss of the cortical bone in the buccal area, okay, or we have a poorer prognosis. So the guided tissue regeneration from the perio surgery, okay, we learn from that to how come and to overcome like these cases. This is a case where we have multiple time retreatment. It could go for a fracture or crack, but when you open up like a exploratory surgery, we don't have any problem with that. So we just add the membrane and the bios, the bone graft, okay, and this is a 6 months later, okay, we still can preserve it. Easily you can go and do an implant, okay, but we even make a space for implant in the future by preserving the bone, okay, and removing the infection, okay, or the inflammation that is around the tooth. Another case, which I did personally, okay, this is a root, okay, and a tooth, okay. The most tooth that you are afraid from, or the worst tooth that you should be careful from, is the upper lateral, because it has the palatal, the distopalatal curvature. Most of the time, we don't respect the anatomy of that tooth, and we go aggressive when we see a lesion from that point. So when I did the root canal, you can see that I straightened the apical area. The apical area was a little bit curvature, okay, in a way, that point, and I straightened the apical area. Do you think it will cause a failure? Yes, because still there is a bacteria I didn't clean and shape, okay? So don't look to the amount of how much you remove, okay, from or how much you fill, but you want to see how much you remove from the bacteria. So when a patient came on 6 months later on, still I have the failure, and I see I have a sinus tract, I went to a CBCT, and I can see the lesion, how size or the big size it is. And I like to flip the skull to see the way also from through and through how the lesion look like. So in a case like that, okay, I will just go for a surgery. So when I open it and I clean it and shape it, looks dark and big like this size, okay? And I just go and fill it, okay, with calcium sulfate. This is how it looks like, and this is 6 months later on. So look how the quality and the healing will look like in just a few months later on. Now, the moral from this case is not really how to do the surgery, but how to prevent to go for surgery, okay? Just respect the anatomy, okay? And you will prevent all the headache you will go through in the next slides. Sutures. Do we have anything that it changed? Silk is not recommended anymore. We go with the Vicryl, okay? The silk is accumulating the bacteria, okay? The bacteria, which is like, will cause maybe a failure, okay, for the intention. We only need the primary intention, okay, for the healing, okay, or the clotting. So we can go by the studies that we have by Dr. Kim, from 48 to 72 hours, okay, we can remove the sutures. So we can remove it at 3 to 4 days in a max. So if you start and do the surgery, okay, on a Monday, okay, and you want to remove it by Friday, it's okay, it's fine, okay? Even before that, you can have it. If a patient comes to you traveling, you can remove it before. But even though it's a resorbable, so it can be removed. But if the patient is annoyed from the sutures, then you can just remove it, and you can just let the patient leave in 3 to 4 days. You can remove the sutures. What type of the size of the suture we can go for? We prefer 6, 0, and 7, 0. It's very small, but because you saw the way how we are making the incisions, okay, it's very delicate area, okay, and we use the microblade, we need to use the small sizes. So we go by 5, 6, 7, okay. We don't want to go less than 4, although we don't prefer it. So it's 5, 0, 6, 0, and 7, 0. After all of that, okay, do you think the outcome will go down or up? Okay, it should go up because we have the microscope, we have the instruments, we have the materials. So it reached now to 96%. So before all days, okay, I'm talking about 10 years ago before, okay, we still have like almost like 60 or even below than 60 for the success of the endosurgery. Nowadays we are having a 96%, okay, of the endosurgery. To conclude all of this, okay, this is before and after, okay, and you can see the difference between the old days and the new days of the endosurgery. Old days we are using the eyes, okay, maybe loupes, but now it's a must to use the microscope. Illumination used before the dental chair light. Using the enhanced, the light of the microscope, it's much more focused. Even it has the light that you can change from the way how you choose the color. The armamentarium that you use now, we are using the micro, okay, instruments. The flap designs, okay, we are now using smaller, we are using the parallel and using very small the blades, so we want to preserve the papilla. Also the osteotomy that removed from the bone, okay, we want to make it the lesser, so we are going by 3-5 millimeter diameter, and you can see that from the micromirror size. The root end resection, okay, we are going with the rear vent and we're using the ultrasonics, okay, the diamond coated. We are now using the materials like the MTA, the bioceram, and we use the biodentin. Also for the sutures, okay, we are using the 6-0, 5-0, okay, not anymore the 3 and less. The post-operative pain now, it's much more less, okay, like before. The outcome, okay, before it was less than 50, now it's a 90%. So finally, okay, I would like to thank all of you, and I meant to put this slide, which is the tooth and implant. They are both, okay, it's a treatment, okay. It's not each one against each other, but we want to make some clarification. I don't like to attend the endo-perio comparison or the endo-implant comparison lectures because it's not a fair comparison. The endo treatment by itself, okay, it's a treatment part inside the tooth, which has a perio treatment, it has a prosto treatment. So we have a tooth, okay, that's a system. The implant by itself, it's a system. So if you want to make a fair comparison, okay, you should compare a natural tooth to an implant. That's the natural, that's the real thing. But you cannot always compare a one single treatment from a system, which is a tooth system, to an implant system. That's not a fair thing, okay? So there is no comparison between endo and implant. It's a full system that we want to save the tooth, okay? Yes, the last one is the endo, but it's a full system together, working together. Pros, endo, perio, all the field together, working together to save the tooth. If we fail, that means the tooth is failed, not the endo failed. And that time we can go for the implant.